Uh, something volume more. Something about hypothyroidism, the basic clinical aspect, how a physician or a GP should approach hypothyroidism according to the latest standards. Basically, understand the three most common hormone disorder. Number one is diabetes mellitus. Number second is hypothyroidism. Number third is hyperparathyroidism. We know diabetes is the most common hormone disorder. Type 1, type 2 diabetes. Type 1 diabetes, insulin is the first, best, and only treatment. What about type 2 diabetes? Multiple drug metformin to sulfonylurea to glitazone to gliptin to SGLT2 inhibitor to GLP-1 analog to different types of insulin. Whichever conference you go, 80% of the talks are on diabetes and 80% of the talks are on newer diabetic drugs, because ultimately we know more than 220 companies are pumping out for diabetic drug and diabetic market. But what about thyroid? A small gland situated in the neck, a 25-gram structure, where are only three major medical disorder. Hypothyroidism. Till date, 99% of people use only levothyroxine sodium, that is molecular name is tetrahydrothyronine, tyranome, L-troxin, euthyrox, 90%. 5% is hyperthyroidism. A single group of drug only, thionamide, carbimazole, methimazole, PTU. Carbimazole 5 milligram, methimazole by Sun Pharma, PTU 50 milligram, cost you one tablet 5 to 8 rupees. So hypothyroidism, one of the cheapest treatment. A bottle of levothyroxine sodium, 100 tablet costing you 150 rupees or 1 rupee 50 paisa for single tablet. Carbimazole, methimazole, PTU, a bottle cost you 600 rupees, single tablet maximum 10 rupees. What about nodular goiter? Actually, there is no treatment in 80% situations. And 10% you can either wait and watch, go for surgery, rarely radio frequency ablation, microablation, or alcohol ablation. So ultimately, sum total thyroid, there are only two tablets, either levothyroxine sodium or hyperthyroidism thionamide, or rarely 1% we are giving T3 now in Wilson syndrome or some other preparation for any patient for rapid stabilization of TSH. But what about the confusion of thyroid? You go through internet, YouTube, and all the social media. Many of the wonderful claim for thyroid treatment. Even now, patients, including doctors. Yesterday, one gynecologist came to me in UAE with a daughter having so much body weight like anything, with a TSH of 6, with an antibody positive with a Hashimoto. She's telling that my daughter is not eating anything, doctor. She's having half chapati full of thyroid. She's gaining weight. Even now, we see people with a TSH 5, 6 telling that hypothyroidism causes weight gain, whereas Harrison itself 16, 17, 18, 19, all addition says that hypothyroidism never cause obesity. It is the most common association of obese females or obese men per se. But all the confusion of thyroid, cabbage, cauliflower, broccoli, turnip, indupa, calipa, selenium, soy products, now millet, gluten, and many of the people claim all the wonder cures, whereas you know that 90% of hypothyroidism is Hashimoto. It is going to be permanent, and 80% of hyperthyroidism to Graves, it is also going to be permanent. Either when it undergoes remission, you follow, it again falls off to hypo, or when it goes to remission, it can relapse in almost 80% of situations. So ultimately, totally speaking, thyroid is a simple gland. One test of TSH costs you 100 rupees. Doing both antibodies, anti-TPO, anti-thyroglobulin, either in Ranbaxy or Metropolis, cost you 400 rupees. Once in 6 months taking TSH, again 100 rupees. Still, our people, we see ladies going from pillar to post, from one endocrinologist to another endocrinologist for thyroid. People go for don't go for diabetes for multiple opinion, because many of the people who go for thyroid opinion actually don't have thyroid symptoms. They have multiple psychosomatic symptoms or fibromyalgia, underlying depression, infertility, obesity, erectile dysfunction, astheniospermia, oligospermia. Everywhere the doctor does a TSH and vitamin D, and nowadays magnesium is another fund. Oh, TSH is low, vitamin D is there, magnesium 1.6, 1.8, and they go everywhere. That is why physicians even now get confused how to adjust the dose of thyroxine, the simple thyroxine, or at time Linorma has come, where to put the T3 tablet. So that is why I'll be just touching and finishing whatever you have to know. The basic thing taken from Harrison or American Thyroid Association guidelines, not the pure endocrine, the research guidelines, but basically you know that when we used to study for MBBS, MD, you ask someone which is the largest endocrine gland in the body, we used to answer the thyroid gland. Now we know it is the adipose tissue, which was once considered a waste energy depot, that is now considered to be the largest endocrine gland in the body. So someone asks you which is the largest endocrine gland, it is the adipose tissue followed by the thyroid gland. We know in the fetus, thyroid is formed from the primitive thyroglosal duct. So fetal thyroid is formed as early as the 3rd week of gestation. In spite of the fetal thyroid being seen in the fetal hypophytics as early as the 3rd week of gestation, fetal thyroid produces its own free T3, free T4 from the 12th week of gestation. That is why the international recommendation to screen for free T4, TSH and antibody before conception, or at least in the first antenatal visit. Because GTT for a 75-gram 2-hour oral glucose for GDM you do in the 24 to 28 week of gestation. Whereas maternal hypothyroidism, you screen before conception or at least in the first antenatal visit. And basically understand, just like any other endocrine gland in the body, thyroid is under the control of hypothalamus as well as pituitary. Hypothalamus produces a tripeptide known as TRH. So basically understand, we studied for MD entrance. TRH is a tripeptide. TRH is a bitropic hormone which causes the anterior pituitary to secrete TSH as well as prolactin. This explains why hyperprolactinemia can be seen in any person with severe, long-lasting, untreated hypothyroidism. But even now, whenever you see a prolactin more than 25, we see many patients going to a gynecologist or even neurologist doing an MRI pituitary and coming and telling the doctor, I have a small pituitary adenoma, 2 millimeter. Many times, it is nothing but a pituitary incident. So whenever you find a prolactin more than 25 nanogram per ml in a lady, first just to do is nothing but a urine pregnancy test, irrespective of the history of married, not married, husband in Kerala, husband in Gulf, whatever it is. First is nothing, UPT mandatory, unmarried ladies also, we see with the UPT positive, they get offended or not. First is a UPT. Second, look for TSH. UPT negative, TSH negative, then always look for the offending drugs. Most commonly, omeprazole, pantoprazole combined metoclopramide, domperidone, nowadays levosulfide, acesulfide. These are the most common agent which cause hyperlactin. So whenever you find a hyperlactin, UPT negative, TSH normal, offending drugs are there, withdraw for 3 to 4 weeks, then repeat the prolactin. Still prolactin is more than 25, then go for an MRI. Otherwise, unnecessarily, that 10 to 20% of the normal people, if you have 3 Tesla MRI, you can find a pituitary insulinoma. That adds on to the benefit of an endocrinologist. We are thriving mainly just like a gastroenterologist thrive on NAFLD or MASLD. We thrive on incident loma. You go for an ultrasound for anything, 70% people find a 1 to 2 millimeter thyroid node. Immediately they go for an endocrinologist, TSH, antibody, TRADS grading, everything. So MRI you do for migraine, everything. 20% of find a pituitary insulinoma. You come here, then invariably you have to evaluate, then follow up, and 1 year, 2 year, 5 year, then loss, follow up, everything. So ultimately insulinomas are on rise. So unwanted imaging should always never be encouraged to be discouraged. That's why I told you, just understand the basic point. And what about glycoprotein hormone? TSH is a glycoprotein hormone. What are the other glycoprotein hormone? FSH, LH, and beta HCG. In conditions where beta HCG is high, as in hyperemesis gravidarum, multiple pregnancy, choriocarcinoma, or in the first trimester of pregnancy, high beta HCG can act on the TSH receptor and cause a transient thyrotoxicosis. That is the most common cause of a high free T3, high free T4, low TSH in pregnancy. Never be over enthusiastic to treat a low TSH in pregnancy. Always be enthusiastic to treat a high TSH more than 2.5 or 4 in pregnancy. Whenever you find a high free T3, high free T4, low TSH in pregnancy, 99% of time it is beta HCG mediated. You repeat the free T3, free T4 TSH 4 to 6 weekly. In 99% situation, at 20 week of gestation, FT3, FT4 TSH gets normal. Why? Because beta HCG has a peak by 8 to 12 weeks, then it undergoes a plateau. So always understand, hypothyroidism you treat in pregnancy, but hyperthyroidism, pure gestational Graves' disease, complicates only 0.2 to 1% of pregnancy, whereas gestation transient thyrotoxicosis complicates almost 4% of pregnancy. One more thing, that's why the basic things of thyroid, just know. When we used to study for MBBS, MD, someone asked you, what is the drug of choice for hyperthyroidism in pregnancy? Our MCQ. I studied MBBS, Government Medical Collective Trivandrum, 93, 99. MD also Government Medical Collective Trivandrum, 2000, 2003. DMK, EM Bombay, 2003, 2006. Even that period, someone asked you, what's the drug of choice for thyrotoxicosis or hyperthyroidism in pregnancy? We used to answer propyl thiouracil. Now we know that PTU, carbimazole, methimazole, everything can be used in pregnancy. But in a newly diagnosed hyperthyroidism in pregnancy, you give PTU in the first trimester of pregnancy and then convert to carbimazole, methimazole. And PTU is absolutely contraindicated in children less than 18 years and lactating mothers because of the risk of PTU associated hepatitis, vaginal scandiomatosis, vasculitis, SLE in the mother as well as the feeding offspring. So as of now, in pregnancy, carbimazole, methimazole, PTU, all can be used. Only condition in the world where PTU used in the treatment of hyperthyroidism is the first trimester of pregnancy. And only one company producing PTU in India, that is Macleods. So this is the basic in total about thyroid. So basically understand, thyroid is simple gland. Goiter may be there, may not be there. Only 3 to 5% of nodular goiters are toxic or malignant. Remaining 90 to 95% is a functional abnormality of thyroid, hypo or hyperthyroidism, levothyroxine sodium, hyperthyroidism, carbimazole, methimazole, and PTU per se. How to change the slide? Next slide. Okay, so basically understand what about the concept of goiter. That's why physician level basic thing that you need to know. So what is goiter? In health, thyroid is neither visible nor palpable. because previously there was a condition known as physiological goiter. So any guy, 13, 14, pubertal boys or girls going to a doctor with goiter, doctors say, oh, don't worry, this is puberty. All your organs are increasing size. So your thyroid is increasing. Don't worry. Then all the advices, cabbage, cauliflower, broccoli, turnip, the same thing. Come after 18 years, just like short children, 5 years, 6 years, going to any pediatrician previously for short, say, don't worry, all are constitutionally in growth and puberty. Eat well, go and play basketball, eat main minerals, come and meet me at 15 years. You come at 15 years, girl have a menses at 14 years, 13 years, bone is already fused, boys have a precox puberty, nothing occurs. So these are all clinical experienced people. That is out. So whenever any person comes with goiter, puberty, that was previously thought to be nothing but physiological goiter. Now, studies have shown that there is no actual increase in thyroid volume during puberty. 80% of pubertal goiters are Hashimoto's thyroiditis. Remaining 20% is iodine deficiency, goitrogen, or dishormonogenesis. The same is the goiter in pregnancy. We know that in pregnancy, thyroid increases in volume by 30%. But clinically palpable goiter is present in only 5% of pregnant ladies. Among them, 90% is Hashimoto. Remaining 10% is iodine deficiency. So the concept is there is no word that is known as a physiological goiter. Any goiter is pathological unless otherwise proved. There can be a pseudo goiter. In Marfanoid people with cervical lordosis, you can be a thyroid popping out. That's a pseudo goiter. There is nothing known as a physiological goiter. And basically, normal thyroid is rubbery in consistency. Thyroid is classically firm in consistency in Hashimoto. You get a soft goiter usually in the early phase of Graves' disease. Whereas you are palpating, you are getting a rock hard thyroid. Usually it can occur in a radial chronic invasive fibrosing thyroiditis or an anaplastic carcinoma or late stage of malignancy thyroid. So simple gland palpation is also important. What about this? Even now, the most educated of the people, the most famous of the film stars who rule Kerala, including actors who is running here and Telangana, everything, she used to come and ask me every time, doctor, in Gulf and all, she comes and me, doctor, what's the diet for thyroid? What diet for thyroid? There is nothing. Just like Anu Mr. Sir had written recently an article in the Indian Express, there is nothing known as a diet for thyroid. There is diet maybe there for diabetes. Probably diet is not there for cholesterol. Your LDL is not controlled by your diet. Probably TG is controlled by your diet. There is nothing known as a diet for your thyroid. 90% of thyroid is either autoimmune stimulation, destruction, or genetically mediated. So what about iodization? We know that iodization is thought to be almost complete. Pockets of iodine deficiency may be that. The required dietary elements of iodine for an adult like you and me is 150 microgram per day. But understand, this is from SPM Park. 10 gram of Tata Namak or Captain Cook that you use in your home contains 750 microgram of potassium iodide. So 10 gram contains 750. So 1 gram contains 75 microgram. So if you take 2 gram of salt also, your RD of iodine of 150 microgram per day is met. But the average salt intake of an Indian is thought to be 15 to 16 gram per day. So actually we are not under iodized, we are over iodized, we are bombarded with iodine. And many of the people believe that it is the rapid iodization which India implemented. 1984 we studied in SPM Park, the National Iodine Deficiency Control Program. We rapidly withdraw the non-iodized salt or rock salt and rapidly implemented the iodized salt. So rapid iodization led to the rapid increase in the thyroid iodine load, silent thyroiditis, release of thyroid autoantigen. Hence the increase in the autoimmune thyroiditis of Hashimoto and Graves' disease, the peak which we saw almost 7 to 18 years back, which is reaching a plateau. So basically someone asks you, what's the diet of thyroid? You eat whatever you want. Probably in a Graves' disease with severe stage, you may have a high protein intake. Otherwise, there's nothing known as a diet for thyroid. Everything is genetic or autoimmune. You eat what you want, but your diet may be for sugar or to an extent your triglyceride per se. What about this? Why do they put this chart? T3, T4, TSH. We know T3, T4, okay, different labs. T3, Harrison 70 to 210 nanogram percentage. T4 is always in microgram, 6.5 to 13. What about TSH? Normal range of TSH is 0.5 to 4. The optimal range of TSH is 0.5 to 2. But different labs give different cuts of hypothyroidism, especially children. Many people come with their children, 8-year, 10-year children with TSH of 8 and doctor, hypothyroid, my child is going weak. So is there a concept of subclinical hypothyroidism in child? There is nothing known as a subclinical hypothyroidism in child. What about the 8-year guidelines which has been published? And the main day now, TSH up to 12 may be considered normal in the newborn period. TSH up to 10 can be normal in a prepubertal boy or girl. In an adult like you and me, TSH up to 4.5. Never be over-enthusiastic to treat a subclinical hypothyroidism. In my father, 80 years, mother, 78 years, don't be over-enthusiastic to a subclinical. In an adult like you and me, 4.5. Adult above 65 years, TSH up to 4.8. Adult above 80 years, TSH up to 6.7. So just understand, newborn period, TSH up to 12. In a pre-pubertal boy or girl, 10. Adult like you and me, 4.5. Pregnancy, 2.5. But basically, TSH more than 10 is hypothyroidism. 4.5 to 10 is subclinical. By heart, just like HbA1c less than 5.6 is normal, 5.7 to 6.4 is pre-diabetic, more than 6.5 is diabetes. Just like that. Whenever you find a TSH more than 10, you treat. Whenever you find a TSH between 4.5 to 10, you treat if antibody is positive. Antibody negative subclinical hypothyroidism, you treat in 5 conditions. Cooper's criteria: goiter, symptomatic, infertility, dyslipidemia, pregnancy. Why? Because even now people come and tell, ladies come and, doctor, when I married, I was 50, first pregnancy I'm 60, second pregnancy 70, now I'm 80 kilogram, doctor, I'm taking thyroxine 150, I'm not losing weight. You take a TSH, TSH is 0.001, iatrogenic hyperthyroidism, still not losing weight. They are telling that I changed the endocrinologist doctor. One doctor put me on T3 preparation also to lose weight. What is going to happen? Nothing. The maximum weight gain associated with severe, long-lasting, untreated hypothyroidism. Suppose I am having a papillary carcinoma thyroid, I am getting my total thyroidectomy done. My TST is more than 100 after 6 weeks. I am not taking thyroxine replacement for 2 years. I reweigh myself after 2 years. My maximum weight gain, if I am doing a diet exercise due to mixed rheumatus hypothyroidism with a TSH of more than 100 for 2 years, will be 2.5 to 3.5 kilogram, nothing beyond that. Subclinical hypothyroidism never causes weight gain. It is the ultimate. It is weight gain which causes subclinical hypothyroidism as a compensatory mechanism to overcome the leptin resistance. So whenever you find a TSH 4.5 to 10 in an obese person, if antibody is negative, your diet, exercise, weight loss, metformin, pioglitazone, and to an extent your GLP-1 analog and bariatric surgery can reverse the TSH to normal. So understand just the concept. Suppose your wife or my daughter at 15 years, TSH causing weight gain, hypothyroidism never cause weight gain. It's just an association of obese ladies. And nowadays, childhood obesity on a rise. Suppose a small child comes with obesity with their parents with a TSH of 9. What is the most important parameter to check in a childhood obesity? It is always the height. An obese child coming at tall stage, be confident, it is nothing but an exogenous obesity, eating cause obesity. Obese child coming in short stage, I think it's an endocrine cause. It can be hypothyroidism, Cushing syndrome, growth hormone deficiency, Prader-Willi, or a pseudo hypoparathyroidism sitting in front of you. So childhood obesity, don't lose immediately. Obese child, be safe. Short child with obesity, think of endocrine cause, definitely refer to an endocrinologist and get it treated. But always understand the concept. TSH more than 10 is hypo, 4.5 to 10 is subclinical hypo. And we know the theory. Now, how much time is there? 3 minutes. 3 minutes. Then I'll finish. So, what about the diagnosis of hypothyroidism? I told you 90% of hypothyroidism that you see in the society is autoimmune hypothyroidism of Hashimoto. 10 people come into the OPD with a TSH of more than 10. You know that 9 out of 10 is hypothyroidism due to Hashimoto. 5% can be due to drugs. Always remember 4 drugs: lithium, amiodarone, interferon alpha, and tyrosine kinase inhibitor, imatinib, sunita. These are the 4 drugs for thyroid function should be checked before and 6 monthly after starting that. So 90% of hypothyroidism is of Hashimoto. How do you classify autoimmune thyroid disease according to Williams? So autoimmune hypothyroidism, thyroid disease type 1 is known as youth thyroid Hashimoto. This is very, very important. Suppose a lady comes to you for recent onset weight gain. You are doing TSH with antibody. Antibody comes to be 1300, 18,420. These are the values of antibody. Patient comes, doctor, my antibody is 3,420. Look at the TSH. TSH is 2.5. So when you are checking TSH and antibody high, TSH normal, that is known as a youth thyroid Hashimoto. Patient is having Hashimoto, but the patient has not developed hypothyroidism. Repeat the TSH every 6 monthly to annually. You treat if TSH is more than 4.5 or more than 2.5 if the lady gets pregnant. Autoimmune thyroiditis type 2 is hypothyroid Hashimoto. You're doing TSH with antibody, TSH more than 10 with antibody positive, it is hypothyroid Hashimoto. Autoimmune thyroiditis, now 2 more means is there enough. Autoimmune thyroiditis type 3 is nothing but Graves' disease. So one is stimulation of antibody by thyroid stimulating, second is destruction. And the last thing, understand, there is nothing known as a goiter, there is an equivalent of thyroid. Previously, you asked someone whether you are having thyroid, we see the patient themselves stretching the neck and telling, doctor, I don't have goiter. And many times during our MBBS days, our surgeons palpate thyroid, Lahi method, Berry method, everything. Nowadays, lady comes to OPD, you go behind and check for Lahi method, Berry method, and you are in the court. There is no Lahi method, no palpation. Anyone tells something is there, go and do an ultrasound. If you want a retrosound, go and do a CT, whatever. So goiter is one among the umpteen number of symptoms having a thyroid disease, because 90% of Hashimoto may be goitrous, or invariably the goitrous also get atrophic time. So goiter is present in only 20%. Even now, our common man have the concept. Guys, you ask for thyroid, no, doctor, my wife has, my sister testosterone low. Men think that they are not having hormone problem. A hypogonadal Klinefelter coming with a testicular atrophy of 2 centimeter with asusper. He also thinks that I am perfectly normal. Never takes his testosterone. A female missing menses for 2 months. She goes to a gynecologist. Gynecologist does an ultrasound, FSH, prolactin, TSH, and picks out the endocrine thing. Klinefelter, most undiagnosed thing. 1 in 550 is Klinefelter. How many Klinefelter has a physician seen once in a lifetime or once in 5 years? You never see, because Klinefelter you always miss, because Klinefelter never come to the limelight. Once you have an azoospermia, they don't bother. Men never get evaluated, female only get evaluated. What are the antibodies you know? So when to check? So you can check TSH. Now, sir, everything is there, discussion you can go on, but basically understand, basically hypothyroidism T4 TSH can be done at any time of the day, because TSH also has a diurnal variation, just like ACTH, the peak occurring in the morning and nadir occurring in the evening. But TSH, the peak and nadir variation is 1 to 1.5 unit only. So morning, evening, noon, bedtime, wherever you do TSH, nothing is going to occur. Whenever you find a TSH more than 10, knock it, treat it. 4.5, 10, treat if antibody is positive, because antibody positive subclinical, the chance of progression to overt is 7% per year. Antibody negative, chance of progression is only less than 2% per year. This is the last slide. But understand the last slide, because 2 seconds is that's enough. So age less than 60 years, understand how do you treat. Age less than 60 years, no history of coronary artery disease, mild to moderate hypothyroidism, start with the higher dose. Age more than 60 years, no history of coronary artery disease, start with the lower dose. But it's not that. Look at the second last 2 sentences. Thyroxine should always and always be taken on empty stomach, even 30 minutes before you take a bed coffee and 1 hour before take a breakfast. But there is no timing for thyroxine. Thyroxine, levothyroxine sodium has a half-life of 7 days, whereas T3 has a half-life of 0.75 days. So thyroxine you can get up at 3 o'clock in the morning and take, 10 o'clock tomorrow evening, 5 o'clock you can take. It has a long half-life, but just take it on empty stomach. If at all you're taking coffee, take after 30 minutes, breakfast after 1 hour. Now Ramadan fast is coming. American Thyroid Association is now recommended taking thyroxine 3 hours after the last meal of the day also. Your iftar, you are finishing at 9 o'clock, you can take thyroxine 3 hours after the last meal of the day also. Always remember 4 drugs: colloid bismuth, iron, calcium, proton pump blockers should be taken 4 hours after taking thyroxine. If you miss up to 3 tablets, Harrison says up to 4 tablets. Previously, once weekly thyroxine has, the basic determines up to 3000 microgram of levothyroxine sodium can be normally tolerated by a normal individual without change in heart rate, ECG, BMD, LFT. The last thing I'll be telling in Stony, how will you stop or treat a thyroxine overdose? I had 2 serial artists who always, every 3 months she comes with thyroxine overdose, come to the OPD. Doctor, I took thyroxine. Why? My husband is cheating, my boyfriend is cheating, to give blackmail case. So every time you ask how many, she will show an empty bottle, 100 tablets. I don't know whether she's taking 10 or 15. This guy will come trembling and always she gets admitted. One lady came 2 times. So how to treat a levothyroxine overdose? Okay, number 1, put nil orally gastric lavage. Number 2, give a beta blocker to prevent the tachycardia or prevent the conversion of T4 to T3. Give a steroid also for prevention of conversion of T4 to T3. Give cholestyramine sachet to prevent the enterohepatic circulation. If you don't give also, nothing is going to happen. Put her in the ICU, observe everything. After 3 days, put her a bill of 1 lakh or 1.5 lakh and send her up. That's the best treatment, because you don't want to die. You don't want to die and threaten someone, I'm going to die, take him to court or blackmailing. Then the best is thyroxine. Potassium you take also, you can pop off. Insulin, you have no guarantee. You have hypoglycemic encephalopathy, you can go off. But thyroxine is the safest thing. And what about T3? Many people who take film stars. When I used to study, Shashank sir had one patient in DM endocrine time, 2003, 2006. These people used to bring T3 tablets from US. That time it was known as Cytomel. Many of the people, now the study says that 20% of people who are on levothyroxine treatment and the TSH is in the optimal range don't get adequate neuromuscular dysfunction cure or brain fog even after T4. For them, addition of T3 to T4 in the ratio of 13:1 may improve the brain fog, neuromuscular and metabolic changes in 20, because free T3 at tissue level is 4 times more bioactive, because 99.98% of T4 is bound, but 99.7% of T3 is bound. Now T3 is available in India, Linorma 5 and 20. This is a small story about thyroid, the basic thing that we finish.